My name is Norman Sartorius. I live in Geneva. I used to be involved with the European Psychiatric Association as its president. I was also in the World Psychiatric Association and spent the greater part of my professional career leading the program of mental health at the World Health Organization. Well, there are many reasons for it, but I think one of the main reasons was that it was a habit in my family to put the boy to study medicine, and this went on for several generations. So this was one of the reasons. The second reason, I think, was that a diploma or a degree in medicine was international. So I hope that I will not be stuck in one single place, but that I will be able to travel. And that, of course, is much easier if you have a diploma that would be relevant wherever you go. And so medical diploma in that respect is a more opens doors, which maybe a study of law or something like that would not do. And then I think maybe I didn't want to go psychiatry, first of all. My original hope was that I would do pediatrics because I like children and I thought it was a wonderful discipline. But since my mother was a pediatrician and a very well-known one, I felt I would, for the rest of my life, I'll be compared with her and say the son is doing better or is not. So I stopped that and went psychiatry. Well, it was really much of the emphasis of psychiatry and the image of psychiatry has been people who were in mental hospitals who were in a terrible state. Very often very poor, with poor care, too many patients together with very little respect for their rights or their individual demands or anything like that. So that was really, there was some psychotherapy that had started, but it was reserved for the rich ones. Those who could pay and afford to have a psychiatrist of their own will in fact have been going to psychotherapy, but it wasn't a widely spread way of providing care. So it was institutions which are not of very good quality as a main form of care. And some additional treatment that has been provided by general practitioners, very little however. It was usually considered as part of the physical illness that you also don't feel well and that you are depressed, etc. So it wasn't given much attention. And a severe mental illness was sent to the mental hospital. Well, I was lucky because I had inspirational teachers, people who had their heart in the right place, who knew psychiatry and who did a very good job. As I was listening to them and learning from them, I think I started to like the discipline much better than would otherwise be the case. Well, the psychiatry unfortunately never taught me much about normal people, normal functions, normal psychological functions. It also did not do much to train me in methods of research, nor in the, for example, standard assessment of the conditions, and many other things of this type which I believed belonged to science. So I took psychology to complement what I was learning in psychiatry, and I think it was extremely useful for me later on, in particular when we were doing studies which required research knowledge. I was happy and lucky to have learned at least the beginnings while I was still a young student. London was such a surprise. Everything was different. They said to me, go and take the money, we'll wait for you in the bank. I said, what bank? I've never been in a bank in my life. And I think it was an immensely enriching experience because they were very good teachers from whom I learned a great deal. There was a number of students from other countries who were there as well, and we met and we were talking together and eating together and learning from each other. It was a different world, and I learned that in a different world many of the rules of behavior and being together are the same, but that there are also interesting things that you have to learn and add to what you've learned at home. At that time, the mental health was covered by a small unit. And the unit, you must understand, is the lowest form of institutional. There is a division which is much higher and a department, etc. It was a small unit, mainly put there because the first Director General of WHO was a psychiatrist. And he said that it's not possible to think about an institution without, like WHO, without a mental health component. So that is how it began. So it was a small unit, and it took me then working there, and so for many years until we managed to lift the mental health unit first to an office of mental health and then to a division of mental health, which made it equal to other divisions, human power development and various other departments which were dealing with other parts of the task of WHO. Well, you're asking me how I started working in WHO, and I did in fact start by being responsible for a particular study. And it was a study that was very important in many ways, because it was exploring the question whether mental illness is the same across the world or not. Whether in fact people in India or in Colombia or somewhere else have the same diseases, and whether these diseases respond to the same kind of treatment. Very important, because before that there was a lot of prejudice, and many of the scientists at that time believed that people in Africa cannot have schizophrenia because they are too primitive in their ways. And I think that to break that impression, a major study was launched by a professor who was at the time, who was from originally from Taiwan. And I came to work and assist him. Later on he left and I took over that project, studying the mental illness in different parts of the world. And it was a wonderful project, because it made me meet colleagues in different parts of the world. It made me understand, to an extent at least, that the cultures, what role they play. It was also continuously surprising, because while in the past everybody believed that psychiatrists from, from Colombia are not as good as psychiatrists from London, it turned out that they are just as good. They are doing just as good a work. And I think that that was another feeling which was very important. And the study itself demonstrated two important facts. One was that mental illness is the same when it occurs anywhere in the world. But the surprising feeling of this finding of these studies has been that the outcome of schizophrenia in the poor countries was better than the outcome of schizophrenia in the rich countries. So we are comparing Denmark and England and the United States and whatever with countries such as India and Colombia and Nigeria. And I think we gradually understood that that was the cause for that, was that people in these third world countries, at the time was called third world, today low-income countries, in fact, after they've been ill and been treated, they were brought back into a family which was fairly large, which allowed them some time to recover, to find again their way in the world. And this made a major difference in the outcome of the disorders. So the outcome was better in those poor countries, and the disease as such was the same worldwide. And I think that was an important finding, and opened the door to a number of other things that we undertook later. We have demonstrated that psychiatrists in a poor country can do just as good work as psychiatrists in the rich countries. We've demonstrated that people can use the same instrument to assess a phenomenon. We've learned that it is possible to do it with relatively little money, because what the money we had was mainly serving to bring once a year these people together to talk to one another, etc. And we learned also that the investment of enthusiasm and goodwill was the main factor that made studies succeed, which I think is an important thing for studies ever since. Then gradually things changed. I was no longer responsible for social epidemiological psychiatry, but I took a greater and finally became the head of the Department of Mental Health, where we had several other topics. We were dealing with biological psychiatry, which at that time, just when I got that, showed a huge increase. So that was very helpful. We were sort of riding on the wave. So it was a department which covered all the main areas of psychiatry, and I think it did a useful work. The first finding is, of course, that you can, when you do epidemiological studies, you can see whether particular populations have more or less of a disease, from which you can discover that maybe there are some factors which are present in one but not in the other setting. Second, epidemiology provides you with data which you can throw in the face of governance and saying, look, you have so many million people who are not well, why don't you do something about it? And if you have the evidence from their country, it is much more than to say, you know, in Denmark there are many people with mental illness. No. It's in the country itself that we have found these problems. So it was both a scientifically useful effort, but it also useful in building programs as such. Sometimes, not always, but epidemiology also gives you clues to the origin of a disease and the manner in which it develops, which is also very important. Stigma, unfortunately, is as old as humanity, and people, I think the stigma of mental illness still exists. The best way to reduce stigma is to establish and maintain a contact between people who have problems and others who don't. I'm not speaking only of the time when people are ill. A stigma remains with you after you've been treated and all symptoms have disappeared. You're still stigmatized as the crazy one, who we don't want to trust him, etc. But the only way to try to change this is to make people meet people who had a mental illness, who can tell you what their experience was, and in whom you can suddenly discover that they are good friends and they are behaving same way as you would, etc. So stigma has been gradually, it's been understood that the most important element in reducing it is human contact with a person who has experienced illness. We've seen that, for example, people who come to a school and tell students about the experience about their illness. The main fact was that the students went out and says, how is this possible? This man is talking just as well as our teachers, but he was supposed to have a severe mental illness. And look at him, he still walks. And I think that the reduction of stigma opens the door to many other things. It opens the door to more research, opens the door to more money, but above all, opens also the door to better treatment of people with mental illness. We have to understand that comorbidity is the rule rather than the exception. Most people, when they are sick from more than one disease. They may have a mental disorder, depression and diabetes, or cardiovascular illness with some anxiety states, etc. It's also very often almost impossible to say to which disease belong the symptoms that the person brings forward. If we don't treat both these conditions, we are very often failing, investing a lot of money, but the patient doesn't improve sufficiently. The argument was that we should really think about, to consider the person in his entirety, to think about what mental and what physical problems he may have, and to handle those problems at the same time. Because if he neglects one or the other, both of the diseases get worse. If you have a person with diabetes and you don't think whether perhaps he's also depressed because he has diabetes, you will find that the treatment of diabetes doesn't go so very well, and the depression will get worse. The importance which we have assessed was that we should think about comorbidity as being the normal state, and that anything that we can do to make health personnel and others understand that one disease doesn't prevent the other is very important and serves to improve the treatment. Well, it's difficult to say. I think that the first book which we ever published, which I published at the time, was a book on the International Pilot Study on Schizophrenia. It was the work of many people. We did it together. We published it together, and I was terribly proud. This was a book that I've never produced a book before that, and it was a wonderful book. It went all over the place, and people were very happy with it, I think. So that was undoubtedly the one that I liked very much. A second one, a book that I was quite proud of, is a book of essays that I wrote about things that I was angry about in our discipline. So I was talking about the behavior of psychiatrists and various other things. I felt, and I wrote a number of essays and published this. I called it my fight for mental health, and I think that it was something that it still remains sort of very dear to my heart. The comorbidity books, I think, are very important as well, because we have seen that people do accept. And what is important, the comorbidity books seem to find their way also to the general practitioner and to the people in other disciplines, which then think about mental illness a little more. I think that young psychiatrists are the most important area of our work. We should enable them to acquire skills which will help them to do their work better. We should enable them to see medicine as a discipline or as a part of human activity that covers both physical and mental problems. We should make them understand that they will have much more success if they work with other people, if they engage the family, if they engage the community, if they engage the government. All of these things they should learn. Unfortunately, today, most of the medical schools, as well as postgraduate training, does not provide any training in skills. You would expect that in the first year of medical school, students will learn how to listen. They will learn how to listen what the patient says. They are not taught this. Some of them have got the good education from home that helps them to listen a little better. Some of them are gifted by nature and listen better, but a very large proportion have never learned how to listen. So people talk to them and they hear the noise, but they do not hear the content. And I think that it's one skill, but there are numerous other skills of that type. How do you speak? How do you convince people? All of these skills should be a central part of the training, so as people go forward. So what I felt was very important was to try to think about ways in which we can help young psychiatrists to acquire the skills which can help them in daily work. And we've done this now. Now we have trained about 3,000 of them, 2,500, maybe a little more, in 60 different countries. And we teach them very simple things. And what is nice about it is not only do they extremely quickly learn those things, but what is also nice is they remain connected. And they talk to one another and they do things together and they become a network, which I think is very precious. So I think that I selected young psychiatrists because they can be bent into the right direction. Somebody should have done it when they began medical studies. Nobody did it. But here they are still at a point where they are accepting that they have to be trained. And once they have learned the skills, they discover that things go much faster and much better. You asked me about the books that I like, or my books that I liked. We just published one on professional and leadership skills, which I think we will be able to let the young psychiatrists have and make it possible for them to learn themselves, because most of the skills are very simple if somebody tells you how to do it and if you are willing to listen and to learn. Well, I think that psychiatry has advanced to a large degree. First, people are aware of the fact that many people suffer from mental illness and need help. That is already very important because it enables governments and others to introduce measures which could be helpful for it. So that's one good thing. We have immensely progressed in the treatment, which I think is fine. And now we can, in fact, usefully act for a number of mental diseases. Not all of them and not completely, but for many diseases, I think the treatment is quite efficacious. Many of the hospitals and institutions have improved, both in appearance and in quality of staff. The problem, however, is that not everybody has an opportunity to get treatment in these hospitals. And while it is perfectly correct that most of the people should be treated out of hospital, there is a need to have room for people who have to be treated in hospital conditions because they cannot be treated at home. So the number of institutions have been diminished, but I think that while this is on one hand positive, on the other hand, it has created the danger that when a necessity arises, an emergency arises, there is nowhere to go. So that is concerning the facilities which we have. Much of treatment now is done in outpatient form. People come and get their treatment from their doctors, but they do not stay in hospital. So that is, I think, all on the positive side. On the negative side, there is still doctors do not treat the person as a whole, so that the general practitioner has to be almost forced to accept that he will also deal with mental problems. He very often is in fact sending the patient whom he has discovered. He deals with their cardiac problems and with their liver, but for psychiatry he sends them away from their own. So that is maybe the acceptance that certain diseases, all diseases should be first treated at a general level, and then the more complicated cases sent forward is not true for psychiatry. Psychiatry very often is sent forward even when it is not very complicated to provide treatment. That is something that we still have to try to change and arrive to do. So I think that is all on the positive side. I think there is also the positive is that people think a little bit more about the human rights of the mentally ill. This is something that has become more and more a subject, I think to an extent fueled by the political abuse of psychiatry, which was present in some countries, fired also by the reports of people who came from hospital and described what happened to them. So that today we have, I think, a fair knowledge about the risks to human rights in mentally ill people. And many of the big institutions, the United Nations and the WHO and every, has in fact not only recognized that human rights of the mentally ill are important, but also make every effort possible to respect them. And to the important thing is to want to add that people whose human rights are respected have better outcome because they're treated like human beings. They relearn how to enter society. And if that is not the case, very often that is not only unjust, but it's also not medically correct. And I think that that is something that one should keep in mind. So that is still we have to still to work a little bit on that. I'm distressed by the fact that psychiatry is still separate from medicine. It is still, the psychiatrists are still considered a little bit aside. And the knowledge of psychiatry is not the knowledge of non-psychiatrists and vice versa. Psychiatrists very often neglect their training in general medicine and will rely on somebody else. It is now people have the fantasy that the modern era of digitalization will allow them to have contacts everywhere. It doesn't do that. It's a very different story when you sit in front of the patient, what it is when you sit in front of the screen. So one has to still work and think, can we make general doctors competent to deal with psychiatric problems as well as with others? And can we do something against what I would call the fragmentation of medicine into ever smaller disciplines? Even in psychiatry, you now have child psychiatrists, adult psychiatrists, people who deal with eating disorders, people who deal with that disorder, a whole range of subgroups. But nature is not divided into subgroups. It has connections between it. And the splitting, the fragmentation of our discipline and of medicine as a whole is very dangerous, and I think is making many treatments which we have available neither not used or used in the wrong way. I think we have talked about stigma. I think that to do something in psychiatry, you will need more investment, more money. There's a huge amount of things that can be done without additional resources. But at a certain point, resources matter very much. If you have a department in which there are people with mental illness, if there are 100 of them and there is one nurse, the behavior of that nurse will be very different from if there are patients divided into wards which are nicely done, in which there are several staff members who can be there and look after everybody. So I think that the fact that we are for human rights in general, not only in psychiatry, means we have to invest money into making human rights possible. And that's we can be terribly upset by the fact that human rights are not respected, but in order to pay them respect that they deserve, we have to somehow make sure that there is also resources that have gone into this, into training, into the institution making, into various things that we are doing in the field of medicine and in the field of health in general and society in general. I think what I said to you earlier, I think that the most important things that we should now develop is to ensure that doctors, general doctors as well as psychiatrists, acquire the skills which they need to do their work better. It's not enough to know how to write a prescription in order to listen to a patient, in order to understand also that what you are doing has consequences which are significant, and to think what consequences could there be when I give such advice. In other words, a skill of understanding the patient, the presence of empathy, the ways in which we are trying to treat the patient within his family or his setting, making sure that the real life is taken into account, is all things that we can learn how to do. And that's why I think that the skills training or learning, acquiring the skills, which are God-given to some, are present for everybody. Bringing people together. There is nothing more important in our discipline than to make sure that we know what other people are doing, that they know what we are doing, that we understand each other, that we teach each other. I think that the function of being the connecting tissue that brings people from different countries and different disciplines together is enormously important. So that is what I see as the one very important role that EPA can play, in that it brings people to congresses, to courses, to gives them teaching opportunities and many other things, always with the mind that together we are stronger, together we can do more, and not only that, we can do it with more pleasure. Modern times have made English more and more a language that is covered, spoken in many countries, more so than ever before. What was previously, there were the 3 or 4 languages were covering much, but now the number of people who are not speaking English is, they don't speak it wonderfully, but they speak it well enough to be understood. And I think the language has helped us a great deal to open doors, who make it possible for people to communicate, particularly young people who speak fluent English. I don't know where they learn it, but they speak it extremely well and and also are able to understand the finesses and the refinement that the language can have. In the area of training, an organization can produce training materials that have been demonstrated to be useful, examined by people from many countries. So that's one line, is the production of training materials, which for all intents and purposes are the best that we know. They are not the reflection of one person only, they are a reflection of many people who have worked together. So one is training materials, training thing. Second, Europe is not a big place and many borders are not open, so people can go and see other people, and organizations such as EPA can maybe facilitate people coming, exchanging, going from one hospital to another or from one country to another, spending a period somewhere and so forth. And of course the fact that the Congress moves from country to country also involves people who are normally not traveling very much to be in touch with people from other countries, and that's a very useful function. What is being told in the congresses is useful, but what is even more useful is that people are together and that they see that they're not alone and they learn a great deal, and I think it's something that is of great importance. I'm not particularly enthusiastic about AI. Why? Because I think it's very powerful and we do not yet know how to use it to the best. It's like giving a child a big knife. Of course, the knife is a wonderful tool, but in the hands of a child, it is a tool that is possibly dangerous. And I think that we generally, in our societies, are not yet capable to understand the power of AI and the things that it can do both wrong and right. And so, before I will be enthusiastic about AI, I want to make sure that people know how to use it, that people are aware of its dangers, its difficulties, its potentials, and that they can use it as their second language. And that will take a bit of training and a bit of thinking. At present, you have some people who are very good at it, but the large majority is about good enough to know how to use the phone. They are not much advanced over that level. And that makes a big tool, strong tool in the hands of people who are not yet learned how to use it well. So I have my reservations. Maybe we should intensify the training of people in the use of the AI. We should make sure that psychiatrists, for example, have a monthly training in the use of, with teachers who are competent, because this is a big tool, so let's learn how to use it. None of it is done. Everybody learns AI by himself or herself. And there is a danger. I think that it will be misused. It can, of course, also be misused on purpose. And that's another danger, because this tool in the hands of a bad person will in fact do ill to very many people as well. Well, in modern times, the position of the woman in psychiatry has experienced two changes. On one hand, there is an increasing number of women who enter into psychiatry, which previously was rare, partly because people had the stigma of the mentally ill being brutal, and the person who treats them must have powers to overcome their physical strength. Partly also because it was very often in remote hospitals, and so in general, women were less likely to be in psychiatry. It so happens that my mother before getting into pediatrics, was in fact doing psychiatry in one of the very famous clinics. And from home, I think she saw and influenced me as well in thinking that psychiatry, that in fact women would do just as well or better than men in the field of psychiatry. But the position of the woman in general has changed to a very large degree. And when you ask me about what do I see as modern developments, modern trends, I think that while on one hand we have now ample proof that women do just as well, if not better, there are still prejudices which say, no, we cannot have a female chief. No, let us be sure that we have a person who knows what he is doing. So I think that although the number of women in psychiatry has increased, in fact, the respect and the expectation that they will be extremely good has not increased. And I think that that's something to keep in mind. Now, the second question about women is that it was considered that women are more likely and more frequently ill than mentally ill than males, which is also a belief that does not stand true anymore. They have the same diseases. They express them a little differently because they're different, but they have the same diseases, require the same respect and the same treatment as anybody else. So both on the side of the patients in psychiatry and on the side of the people who work in psychiatry, we have to do a bit of work still to make people accept one another regardless of whether they're males or females with equal respect. No, I don't think so. I think that I would do very much the same. I had good things and bad things happening, more good than bad. And I think that things where something went wrong, if I had to start again, there'd be some other things which will go wrong. On the whole, I think I would not change things as I was doing. I think I would still think that we have to learn medicine, psychiatry, and psychology, as well as some human sciences to be a doctor. I think that we should combine the knowledge that we have with the experience and knowledge of the patients who are in front of us. I think that we should do many of the things like that. And I think that that was the case before, still stay the same. I think friendships. I think that the friendships and the power of being with other people, which has become easier now. We travel more easily, we phone more easily, we write more easily. So the power of being with other people, and power also, I think, with other colleagues, the option that you can be with other people very much. An immense value of mutual support and the tremendous importance of social capital, in which there is none who is alone in the world, but all in one way or another linked to one another, is an ideal that we should keep before our eyes. I think we should connect with one another and respect one another. These are the two things that would be very important, I think, for the future of our development and for building the future together rather than in some other way disturbing one another in its efforts. I congratulate the EPA for having undertaken to produce various ways of communicating with colleagues and possibly also with people who are not in psychiatry.